the end. I'm going to ask Dr. Peel to proceed with his presentation. I have it quoted on PowerPoint.
Now I have an overhead. Is it showing to get up there? Well, it's a great honor to be here to participate with you. And of course, the policy innovations that you've brought on are critical, just to the idea that we need to explore ways of thinking about addiction and dealing with drugs. The low threshold for people getting services, the diversity of the services, the recognition that some people don't need services at all. They're all remarkable innovations. There's some underlying concepts I just want to explore a little bit, and partly they have to do with the different context in America, and partly they have to do with some ideas that are general, possibly even in your context, that need to be explored. So let me begin by asking people in this audience, has anybody ever taken a painkiller? Raise your hand, please. Did you become addicted? Isn't that a remarkable thing? Opioid painkillers are the epitome of an addictive substance. When somebody like Sam Quinones writes Dreamland, he devotes a chapter to describing how the opioid molecule addicts you. And you talked about the fact that addiction is widespread across all elements of society. Everybody in this room virtually raised their hand. Oh no. And yet, nobody in this room is addicted. Can somebody just, the man with the glasses there, can you explain that to me? Me? No. You can't explain, isn't that a fundamental thing to understand? Isn't that a basic thing to understand? And you said, well, we can't say that any group is free of addiction. Is there something special about this group of people? And everybody took an opioid and not one person became addicted. So doesn't that cause us questions of fundamental assumptions? So you did say something about the way we think about problems is critical to the way we approach them. I very much agree. And I want to possibly go even a layer deeper in thinking about this. And I want to talk in particular about the damage caused by a way of thinking about drugs and addiction in America. And I have to apologize in advance because, it may conflict, well, a little bit with some things that were said, like that everybody's equally susceptible across all of society. For example, am I allowed to contradict him at all?
It was a symposium. We're encouraging individual views.
And it's going to challenge your own ways of thinking. So just remember, everybody in this room has taken the most addictive drug identified, and nobody in this room was addicted. Well, can somebody give me one reason why nobody in this room was addicted? Can you tell me why you didn't become addicted to a painkiller, miss, in your green sweater? You don't have any idea why you didn't become addicted? A group of thoughtful people has all taken the most addictive drug. So nobody wants to volunteer an idea? Well, I'll throw out the one.
When I was on it, I had a healthy amount of respect and fear for the potential, and I'd already had addiction in my family at that point.
So the fact that you had addiction in your family was a preventive, which isn't usually the way people think about it. Anybody else? Why you didn't become addicted?
I think this is probably a group of people who are all socially connected.
All what?
We're all socially connected.
Damn.
That helps to prevent.
What a crazy idea. So you sort of had like a life. Socially connected was the term you used. I don't know, maybe you had like a family or a job or various obligations and connections to the community. So you had this addictive drug, but you didn't become addicted. And you did talk about a holistic approach. But the most determinative thing wasn't the drug, but the context in which it was taken. Oh, I already did this one. So now explain this. You use the term opioid overdose. I'll just throw out some crazy facts. Don't attack me. It's virtually impossible to die from an injection of pure heroin. So this is American deaths in drugs, 2017. There's a lot going on here. The synthetic opioids, shoot. But heroin went up too. At one point, people thought that wasn't possible. Because the concept was, well, they start taking painkillers and then they switch to heroin. Both of them have hit record levels. Natural and synthetic. But while we're at it, something we haven't even talked about, methamphetamine, cocaine deaths have also peaked. What the hell's that got to do with anything? And they don't have benzodiazepine deaths here. And they've peaked. So why is everything going up? Heroin and opioid, synthetic opioids and painkillers, cocaine, cocaine and meth, and benzodiazepines. Why is that? Why are all deaths going up in America? Isn't that the critical thing we're here to lady in the back?
So my only thing, 9/11 happened in what, 2001. So it takes about anywhere, so it is signed out to like a 4 to 6 year contract. Maybe if they do 10 years. And then for the VA, there was a tendency of just giving soldiers opioids to ease the pain. So maybe just with that population, I'm not saying everybody, but that's a population that definitely had a significance with being prescribed opioids.
Can you help translate what she said for me?
No, I don't know what she said, but I can answer. I'm sorry. No, I was just going to say that I was thinking that maybe because fentanyl is mixed in with some of the substances. At this
Well, one thing I got to say, apropos, there's no such thing as a heroin overdose. They double count things when you combine drugs. The New York Medical Examiner's Office is the most thoroughgoing toxicology of dead people thing. And they say 93% of people who show up dead have more than one substance. So right away, use of the term overdose is misleading in a potentially fatal way. If you were to know, and it affects policy, giving people a pure dose of a narcotic, generally speaking, is benign. So, I mean, my next puzzling question, are you aware, one of the two main policies I'm going to discuss is reducing painkiller prescriptions in the United States. What do you think has happened to painkiller prescriptions? The lady nodding her head for the last 5 years.
They've gone down.
They've gone down. I don't have great graphic capabilities, but if I were to draw a graph, painkiller prescriptions would go like this. So one of our main policies, endorsed by everybody, harm reduction, AMA, the Christie Commission, is to stop giving people painkillers, and yet we've succeeded at that, and yet their deaths are going. Can you explain that to me?
Because someone's not allowed to get a prescription from their doctor, they're more likely to go out and get street drugs.
That's the most obvious reason. When you make it hard for people to get medications in a legitimate way, you're going to do better in general getting it from a doctor than on the street. I'm the last person in America to defend doctors, but we're now vilifying doctors for giving pain medications. And this is one consequence. But I'm going to tell you another, before I get off the stage, if I'm not dragged off, is there's a way of thinking underlying all of this. This is a fascinating quote here. I think a fascinating thing is Jowl is a family doctor. A family doctor would never be put in charge of addiction services in America. Only a psychiatrist or a neuropsychiatrist would. So that's a whole story in itself. Patricia Harris, chair of the AMA Opioid Task Force, said in the press release, while this progress report shows physician leadership and action to help reverse the epidemic, more than 115 people in the United States die every day. That's opioid related. So she doesn't say overdose. Isn't that a funny statement? She's saying we're doing much, much better in reducing prescriptions. Unfortunately, people are still dying at increasing rates. Isn't that a funny statement to make? What if that policy is actually causing the deaths? How far down does the prescription level have to go and the death level go up before we say, you know, we're not doing the right thing? Everything traces back to one idea, by the way. Drugs cause addiction and death. That's the major, fundamental assumption that drives everything, all of these things that we're talking about. So, if taking painkillers causes death, cut down painkillers, people stop dying. But that's not the way it works, at least in this situation. Okay, we talked about methadone. Everybody endorses medicine-assisted treatment, which is fundamentally substitution, methadone, buprenorphine, Suboxone. A typical critique we hear is, we can't do that in rural areas. It's hard, how are you going to have a methadone clinic in South Dakota or Iowa in a farm country? And we've been doing it, it's pretty readily easy to get Suboxone or methadone in a major American city. Unfortunately, can you read what it says on the board there? The highlighted, underlined blue letters? Yeah. Help me out.
Large U.S. cities see big jump in deadly opioid overdoses.
The largest jump in heroin-related drug deaths is in major cities where now MAT is a regular feature. So our two main innovations in response to the opioid crisis, reduce prescriptions for painkillers and increase MAT at a minimum, have not done something, and at a maximum are associated with greater death rates. Wouldn't that be a kick in the head if all of our concerns were translated into actions? I'm glad you're smiling. You're not going to call security, are you? Okay. It's always a danger when I speak. By the way, what's the toughest addiction to quit, do you reckon? What? Tobacco. Has anybody in this room quit smoking? Raise your hand. This is a pretty well-versed group. How many of you received treatment to quit addiction, to quit smoking? Look around. You're the only, and you're the one on camera. A third of the people raised their hand, they quit smoking. Everybody, the hardest addiction, I do this in front of real addicts, people who've sampled a range of addictions, consumer experts, and they always shout out nicotine. And I ask how many have quit. You know, half the audience says no. Here, a third of the audience, not one person said that they received treatment to quit addiction. Tell me what that's about. Because everything we're talking about here is about treatment. Were you one of the people who quit smoking? Why did you quit smoking?
Too expensive.
Crazy nut. Why did you quit?
Well, I was just going to say, there's not a lot of treatment available to quit smoking.
There's a ton of treatment available. You can buy it in any pharmacy.
There's a passion.
Well, can somebody give me some reason why they quit smoking? Like, people will say, well, my daughter and my child said, Daddy, don't you love me, or something, or somebody will say, I quit smoking 8 or 10 times, and then I succeeded. People just sort of live their lives, things impinge on it, the cost, the impact it has on others, their own personal concerns, and eventually they come to a place where they quit. Is that a crazy idea? Nobody in this audience, a third of whom would quit smoking, received treatment. Not one. The hardest addiction to quit. Do you notice one thing I tend to do is to go back to the people who believe things and ask them about their own experience? And isn't it remarkable how their own experience contradicts what their beliefs are? Because people think, well, you have to get treated to get over addiction. They think, well, opioids are inherently addictive. That didn't happen to me or anybody in the room that I'm with. But I believe it anyhow. So I have a crazy theory. It's the global warming theory of drug addiction and opioid deaths. We're going to believe something and continue to believe it even while it's killing us. We're like the Republican Party, but doesn't believe in global warming until, New York is underwater. We're going to keep believing drugs cause death by overdose. It's the drug that causes the death until, when the death rates keep going up. At what point will we become discouraged from those beliefs? He said all drug deaths occur to all people equally. A crazy guy named Rahul Gupta was appointed health commissioner in West Virginia. He was trained in India. He didn't do a sampling of drugs. West Virginia is the leading state for drug deaths in the United States, 52 per 100,000. He investigated every drug death. He didn't do one of those crappy samples. And he found incredible comparability of everybody who died. Do you think young people die more of drug overdoses or middle-aged people? What's that? Now you've peaked. If it was overdose, it would be young people, wouldn't it? Long-time drug users are not going to overdose. As soon as you say you're a male between 35 and 54, you're having a totally... The use of the word overdose is misleading in a clinical and policy-related way that produces death. What's it say to you when you learn that they died from 35 to 54? What's that say to you about the person who's died? You. What's it say to you about it? Yeah. It doesn't say one thing to you. You know something clinical, a fact about somebody dying, you have no point of perspective on that?
Midlife, so...
What's that?
They're in their
Midlife is a word for what's happened. What's it tell you that he died in midlife? What's that say to him about him? As opposed to a drug overdose, what's that suggest?
long-time addict.
Long time's important, isn't it? He's been using for a long time. Probably a lot of things have contributed to his death. I knew you could do it, buddy. I knew it. Me and you working together. You're going to get all the right answers. With less than a high school education. This is the United States, and I don't know about Portugal. He didn't make these numbers up. People who died in West Virginia were 35 to 50 or 40-year-old men with less than a high school education, and you're single. Remember that guy? Well done. He said they're not socially connected. An isolated man with little education, bad employment, virtually all of the opioid deaths in West Virginia fit that description. Which would get back to my question to you, why did nobody here become addicted? You don't fit that description in general. The highest county, one of the highest counties for death is Baltimore. They have a different profile. Overall opioid overdose deaths, I had to write in I wrote poisonings to replace overdose. Among black men between the ages of 40 and 69 increased 245% from 2014 to 2017. Same age range, they're not the same. West Virginia is a white state, forgive me, but it's a similar population in many regards. So if you think rich and poor people are dying equally from opiates in America, that's not true. Not true. It's not true. So why are we always selling that opioid deaths are an equal opportunity destroyer? Why are we doing that? It's another way of saying what I was telling you. Drugs are addiction. It's a way of focusing away from people onto drugs. And I think you're focusing a lot on people. So we can attack drugs, which is an underlying approach that Americans have. People are taking drugs in destructive ways. By the way, that group of people in West Virginia, they're also dying from alcohol, of course. They're also dying from suicide. So, I mean, we can call it a drug death. So we can avoid complicated social solutions. Saying people die of overdoses is a way of saying, what the hell are we really going to do about single unemployed men in West Virginia? What are we really going to do about that? What are we really going to do about Baltimore? What are we going to do about it? We don't know what to do about it. So let's talk about drug overdoses. Although, as I said, unfortunately, that increases the death rate. Is this a drug problem? It's a trivariate problem. It's an experience or an involvement. It involves a person in a situation. You remember Vietnam data, over 90% of returning Vietnam veterans who were addicted to Vietnam ceased to be addicted in the United States. Same person, same drug. That's a radical shift in your life network. Rat Park's a famous study. Rats have been shown to be addicted in individual cages, but if you put them in Rat Park where there were a lot of other rats, and you could, how can I put this in a way, fool around, they were male and female rats, they stopped taking opioids even if they had previously been addicted to them. Which brings up, sex is a more powerful motivation than drugs and drug discontinuation. This is a critical point. He said that they have a medical approach. They don't have what we think of. Well, I think you brought that out a lot, I hope. That's where you were headed. Medical approach means something very different for a family doctor than it does in America, where you put somebody in a rehab for a month or 3 months and then do Lord knows what to them. You don't do anything medical to them. You don't affect their brains in any way, shape, or form. You generally go to 12-step meetings. Just a little history while we're here. Endorphins, a man won a Nobel Prize for discovering the endorphins in 1968. In the early 1970s, a man became famous, Dr. Richard Estad, for doing, this is before some of you were born, programs on public broadcasting, The Brain and the Mind, where he claimed we would solve addiction and all mental illnesses. That was in the 70s. How are we doing so far? How are we doing so far? But we still love to believe that. Addiction is a people problem. convincing people otherwise. And here's my bottom line. Both as a society and individually, convincing people that drugs cause addiction that concept is itself a cause of addiction. We're getting rarefied here. It's a hard concept to get across. The way we think as a society, the way you think as individuals, and the way addicted people themselves think is a cause of their addiction. And people are more inclined to believe that drugs are uncontrollable, or in fact, more likely to become addicted, and yet we have a societal mandate to convince people that they can't control drug use. That's what we teach kids in school. Do you follow my logic? So I have an explanation for why drug deaths are going up. My explanation, aside from people going out in the street and buying fentanyl from a local mixture now, fentanyl and tranquilizers, is that we're creating a mindset for our society and our population that makes it more likely that people will be addicted. Here's one last slide. Before I say that, I'm quasi-famous because in 1975 I wrote a book called Love and Addiction. Let's jump ahead to 2013, and I hope people are taking notes, people here who are in the Nobel Committee. The Diagnostic Manual of the American Psychiatric Association didn't label a single drug as being addictive. That's not how they approach it. Substance use disorders are mild, moderate, severe. But the word addiction does appear in DSM. And they call it behavioral addiction. But it's in the same category. Substance use related and addictive disorders. They've got sort of two categories. But I don't believe that. Addiction takes place with regard to an experience that people become absorbed in that is increasingly destructive in their lives. When I leave here, I got a confession. But let me ask you a question first. Do I look pretty good in this suit? I bought this suit on Flatbush Avenue yesterday. And I was commanded to buy it. And perhaps you might guess, my mother's dead. It wasn't my mother. I'm going to a fundraiser in Chicago. Mayor Rahm Emanuel's going to be there. And they said, Stanton, it's formal. And I said, oh, uh-huh. They said, you're going to have to get a suit, Stanton. So I bought this suit yesterday. Yes. Tie came with shirt. I like the whole 9 yards. Above and Beyond is a program started by a man named Brian, doesn't have to do this over again, designed by a man named Brian Cressy, who's a kind of billionaire healthcare investor. And it's a family recovery center in the center of Chicago. Remember how I told certain disadvantaged groups are more prone to addiction? And ironically, in the United States of America, because they do have public health, they do have a government health system, those are the least serviced areas for everything. Regular health, let alone any kind of treatment. It's a drop-in center and it's a behavioral center. It's not a disease center. And it focuses on teaching people skills and helping them adduce the resources to live. It helps them with jobs, with education, with general health problems, with marital problems. They have marital clinics. It's a full-service place. That's where I'm going. I went to the airport directly from here to go to their fundraiser tonight. And I want to just list one other thing. I'm actually a service provider in Portugal. Do you believe that? You don't believe it? Oh, it's not. How is that possible? I had a rehab at one time, and now it's an online program called the Life Process Program. And I have coaches who deal with a general, it's easy access. People get online, they fill out profiles, they can interact with coaches video-wise, or they can follow a protocol that I've created and answer questions and the coach responds to them in written time. And it's a worldwide program. We have clients in Portugal. So I just want you to know that I'm a provider and you're estuary there. All right.
Welcome.
Thank you. Any way I can help out. So I just don't want you to think that I'm out here critiquing the world without doing something. I want you to know that in my own small way, as a private practitioner, and as somebody who's on the board and whatever, a clinical advisor to Above and Beyond, that I'm trying to translate into action everything that I've said here. So this is my last slide. SAMHSA is the Substance Abuse Mental Health Services of America. That's a government agency. They went and did a generic survey of mental health professionals and addiction experts, and they say, what is recovery? Which is a critical issue. And in America, well, as Kasha brought out, in America, recovery means abstinence. Abstinence wasn't listed as their 4 pillars of recovery. Health. We talked about having general health care. Before you even treat people for addiction, people are going to do better if you're dealing with their diabetes, if you're dealing, they have infections. They need a general level of health. Home. We're dealing with basic principles here, aren't we? And Above and Beyond, that a large part of that population is homeless, which might be different, I think, than possibly the Portuguese population. So one thing they address is that, giving people a place to live. Purpose. What's that mean? Having people have a purpose is a point of recovery.
They have a place in the world. We're connected.
Say that again?
They have a place in the world.
They have a place in the world and a reason for being in the world. There's nothing more critical to avoiding addiction in the first place and to overcoming addiction than purpose. Purpose. And the last thing is, apropos of our friend here, community, relationships, and social networks, which is what Above and Beyond tries to provide. Allowing people to connect to other people, which in a way is their kind of whole society-wide approach, is, along with purpose, the most critical thing for preventing and overcoming addiction. And none of these things are about the drug itself. None of these things are about the brain itself. None of these things says disease in itself. All of these things are social, which is very much what I identify with the Portuguese approach. So I have a little bit of a different approach. Thank you.
And our final presenter is Beth Conley, who's now with the Pew Foundation.
Thank you, and thank you for inviting me. It's a really amazing panel. I'm honored to be here today. So I'm Beth Conley, and I direct the substance use prevention and treatment work for the Pew Charitable Trust in Washington, D.C. Formerly, I was the Commissioner of Human Services here in New Jersey, and so the mental health and substance use work did fall under my department as well as Medicaid. So we had a lot of connectors that were all important in actually addressing substance use across New Jersey. So So I'd like to tell you a little bit about my work at Pew, and then I'd like to reflect on some of the things that in Portugal, which I really applaud the leadership for taking such an overall role for an entire country. We find that it's hard for some leaders to take an overall role in one state. So the fact that someone was thoughtful enough to address and bring the right people to the table is really admirable. So our work at Pew, we go into states where we're asked not to step in where we're not wanted, and we do a systems assessment of the state and their substance use treatment network and their policies and their regulations. And we look to find places where states might be able to advance access to treatment, where they can advance uses of MAT, what types of policies they might want to explore in advancing substance use treatment across their state in more of a unified and coordinated manner. And I thought that this coordination you pointed out was excellent, that everybody came together. I can tell you, we looked in the states. We explore many states all the time before we select a state to go into. And coordination is oftentimes one of the things that we look to and see that there is an uncoordinated effort, if you will, that the Department of Corrections is doing something, the Department of Health is doing something else, and nobody's talking to each other in order to facilitate a person-centered approach to treatment. We then will work with legislative leaders, we'll work with the executive branch, we'll work with providers in seeking out how to leverage funding, whether it be Medicaid funding, state funding, bringing in some federal funds. As I'm sure you all know, we've never been so flush with money directed at a particular crisis as we are with the opioid crisis, with the federal SOAR grant, with the STR grant. All of these, and states are trying to figure out how can they best utilize their funding. One thing that Dr. Manalska pointed out was that everybody agrees in treatment, and everybody agrees that we should have treatment, yet only 23% of the publicly funded treatment centers in the United States offer MAT, medication-assisted treatment, which means that we have 77% where you can only get one kind of treatment. So if you knock on that door and you look at treatment and that's not the best fit for you, you don't have any other options perhaps. And if we have a publicly funded system, as Portugal has offered everything, when you walk in that door, you can access whatever it is you need in particular. So we really have to work on advancing a publicly funded system to make sure that we have every form of treatment available when people do actually walk in the door. I thought that was really important. Care coordination is incredibly important. We see in states where people exit the correctional institutions and there is no warm handoff to Medicaid. There's no warm handoff to treatment. We've seen some cities that are doing work, and not statewide, but some cities that are doing work in providing treatment behind bars, which is wonderful, except when someone walks out the door and there's no treatment for them to continue. So these disconnects really are things that states need to be looking at and addressing on how do we establish a continuum of care where people can flow to the best end possible. One thing that I thought was very interesting is that stigma, we're finding stigma plays an incredible role. And it seems that your universal approach and the grassroots up has really helped to ameliorate the stigma. Yet we find that a big example from a meeting that we were at was that we have coroners who won't report an overdose of drugs as an overdose because they don't want an opioid treatment facility housed in their county. So we have yes, and I know I agree. I have no poker face, and so it is very hard for me to keep a straight face when people say that. So I know that the numbers that we're seeing, they must be underreported if we are seeing pockets where people are not reporting what they're seeing. We have judges that believe, and I know that we have criticism that where some places they believe that really the best form of treatment is to put someone in prison rather than to find a diversion to actually access treatment, which again leads sometimes to our bigger problem of the access of treatment. we did point out that the social determinants of health are very important. And again, this speaks to a coordinated effort. It speaks to treating people holistically across all departments in states and making sure that we have everything available to us so that we can actually see the downward trend in addiction rates and deaths. So I really do love the integration, and I would love if you could talk about anything seen as you carry your work farther, because for me, there's a lot of things that I can advise on to states and that we've done work on in terms of leveraging financing, working in a more coordinated manner. But for us, stigma really has been one of the most difficult nuts to crack in terms of bringing treatment to different areas of the United States.
I believe that the drop in stigma was something natural, coming very much from the spread of the problems, as I explained, among all social groups. And since then, it says, when I started working in this area, and we started to develop a network of treatment, anti-addiction, and so on, people tended to do not accept as well the creation of a network addressing this problem, because we had some lack of responses in our other areas. By spending so much money and having so much resources, so much professionals dealing with this area of activity, while in other college, in other places, in other subjects, we could not deal so properly with problems. And then the consequences that came out from this problem, HIV infections, all those overdose infections, people started to look at, okay, this works, invest in this. And as long as it will up, the responses will up, also the acceptance of it. After our strategy, for instance, in 2000, we started to develop positive discrimination policy. That means, okay, if you find a job, if you offer, you accept someone following the treatment, you accept it in your company, you have tax reduction, and we are able to support the minimum wage for 6 months. After that period, it is up to the employer to decide if he keeps or not his employee. Up to them, and there's a direct connection. We are on the backyard, but we get out of this relation. Everything went very, very well. Okay. We found thousands of jobs for people in these circumstances. But it happens mostly in micro companies. Next door, car repair company for employees. Then the financial crisis, social crisis came. And those companies went bankrupt. And most of these people were fired. Lost their jobs. That's why we have so many labs and difficulties now. But it was very difficult at that period to advocate for the research for keeping the product. When unemployment in general population reached 16%, we could not claim, okay, we need positive discrimination for these people. We want to have, otherwise they do not get access to it. Then the the government decided to close this problem, positive discrimination. And any attempt to rebuild this building that was in confront with feeling of popularity. When people started to say, why do you have this positive discrimination when I, a citizen without his past, without his story, I cannot find an employment? It's not fair. So stigma started to increase when people were more selfish, when people were more centered on their own difficulties. In times of better well-being, social well-being, people tend to be more institutional. And this start to feel again this situation, which much more accepted nowadays after we jump into that difficult time, to develop new responses to offer new things to this population. That's why we are, for instance, on our way to opening safety checking sites for these populations that relapse mostly, and the studying for it and finding the means to do it is very well population now. Okay. So I would say that stigma comes and goes with the social environment. Nowadays we are making progress on it.
Okay, we're about to open up to questions from the audience. I'm going to take the prerogative of the coordinator to kind of sum up what I heard and the takeaways, at least for me. One is that if we're going to be successful, and I think Portugal's model shows us, we need a system of care. We need a coordinated continuum to be able to address all the needs that people have. I think two is, I think several of you mentioned this in different ways, we need a system that integrates social and health so that we deal with the social determinants of care as well. We have a big movement in this state and nationally about the idea and health of housing first, that you can't deal with behavioral health issues unless people have a stable home. And I can see what Dr. Peel is saying, a stable community, a reason to live, a sense of connection to the world. And the other thing that we had in this country that I heard a little bit in Portugal that we missed, is we had some type of government regulation to set forth what are the standards, what are needed. My concern is, as there's lots more money coming, as Beth mentioned, that we'll use it to fund individual treatment centers with lengthy stays. That'll have a profit motive. So that sometimes we had a system called Certificate of Need in health regulation many years ago, where the government insisted before you could open a facility that there be a study done to see if it was really needed or redundant. So I think all those things contributed in Portugal to just a wonderful success, and I congratulate you. And I want to say, Gabriel, I'm delighted with your presentation. I think it stimulated some thought here, and to me, it connected the social determinants with all the medical and other issues we need, including certainly law enforcement. And Beth, it's great to hear what the foundation is thinking of and doing and its work from states. Let me stop talking and take some questions from the audience. Yes, Carolyn, and then you, sir.
Why did Portugal decide to decriminalize rather than legalize?
Well, it was not in the horizon 20 years ago. Let's go back to that period when I believe and as I said, the only boundary that was put to us were the treatments. So we were and we still are moving in a prohibitionist paradigm. Okay. So this is the frame where we could move. Of course, nowadays we are thinking different ways. We are following in a very attentive way the experiences that are taking place in other parts of the world and here in the United States, mainly in Canada, in Uruguay. But I would say that our society and our political spectrum are quite happy with the situation that we have nowadays, with the improvements of the situation that we achieve.
Good, thank you. Yes.
Hi, how are you? Thank you for your presentations, all three of you. I work for the New Jersey Division of Mental Health and Addiction Services, and I oversee our opioid treatment programs in the state. So we have 32 licensed opioid treatment programs. We're located in 17 out of our 21 counties, so we still have 4 counties. You said that making medication more accessible and methadone, getting that more accessible was part of some of the success. What are the regulations for Portugal? Because in the United States, the regulation of methadone is really intense. So I'm just wondering how it is in Portugal or other countries.
So, methadone is a kind of here, our network of centers has more or less the monopoly for the use of methadone. Our doctors are trained to prescribe it, and with our staff is trained to deal with nurses, etc. Prescription is made by doctors. We can agree with some NGOs after training, after there are no special conditions to give them a license to prescribe. First, it's given to the doctor, sponsored for the NGO. In the low threshold program that we run in Lisbon, for instance, is run by NGO, and the doctor, the psychiatrist, who worked with us in the public service prior to moving into that NGO. It's a well-trained doctor, so they can, and we provide that methadone for free, methadone that they use.
Okay, because in the United States, you have to become a licensed opioid treatment program. So private physicians in our state can only, they can prescribe for pain with methadone, but they can't prescribe methadone for somebody with an opioid use disorder. So it sounds like a different type of system.
Yes. If I, as a doctor, I work out of the system for treatment for dependence, I must ask a colleague to prescribe. So I respect my English.
If I can add, because I understand the intention, I think, of that question. And what's interesting in Portugal is that because methadone is so easily available, buprenorphine is not popular. Because everyone got used to methadone and it's so easily available. So buprenorphine is not available, but I think buprenorphine is a part of the solution to the questions that you're asking because it's not as tightly regulated. So I would say that, I would think that if buprenorphine can be made available as widely as methadone is in Portugal, that's also a good thing, yes. Right? So I wouldn't get stuck on methadone. I would just think about what substitution can be made available as widely as possible.
Right, and some of our regulations right now that we're working on in the state, because our substance use disorder treatment programs have some barriers to even prescribe methadone because they're not licensed as an opioid treatment program, so we're trying to, alleviate some of that.
And if I could add, the new the legislation that the President just signed expands the practitioners that can actually prescribe buprenorphine. So should be more positive.
And we're actually going to work on, under our new grant, the State Opioid Response Grant, we're going to work on low threshold programs within syringe access programs to make buprenorphine more widely accessible there, as well as we're increasing buprenorphine training throughout the state through Rutgers and Rowan University.
Great. Yes.
Hi, I'm Suzanne Boris, and I'm the Assistant Director of the Division of Mental Health and Addiction Services in the state of New Jersey. And my office oversees a lot of stuff. But two of the areas I oversee are early intervention and prevention. And we've developed a whole bunch of programs, through federal grants. One is known as our opioid overdose recovery program, where we, when a person is reversed from Narcan, drugs, or ED, a recovery specialist will meet with them. There'll be a patient navigator, and then we'll get that person into some form of treatment or recovery support, whatever that they want or need, and we're having, really good statistics on that. So, and right now, we're in all 21 counties in New Jersey and in 52 PDs out of 72 hospitals in New Jersey. So we have a really good coverage, and I'd like to try to get those remaining EVs done. We're also implementing, I'm coming at it more from an angle of overdose prevention, reducing overdose deaths. So, my focus is more on the prevention angle. I work very closely with Adam too, and we do, certainly promote the expansion of MAT, but we're trying to do those things, like Samson says, to, engage people in helping them have a meaningful life. But what's frustrating to me is our overdose death rate keeps zooming in New Jersey. So I'm having some conflict here. We have this wonderful program, our own program. We started a program called Support Teams for Addiction Recovery, where we have finally a case management model for addiction services in New Jersey. We had nothing like that. So with the last round of grant funding, we were able to implement these STAR teams, and we're hearing incredible stories. Those teams are to engage that person, get them employment, get them education, get them housing. We're hooked up with our DCA that does housing vouchers, and we're able to assign vouchers to that. They tell us one story of a woman who lived in a car for 2 years in Walmart, and they finally got her a house. They helped a guy who was having all kind of legal problems, and they went before the judge and got that rolled out. So I'm just looking for suggestions, but we're trying to do what we think is the right thing, with engaging people and really focusing on the recovery. Because one of my concerns is yes, people need treatment. That's not, of course, I'm not going to say anything's wrong with treatment. But my problem is then we're done, treatment done, tools. And, this is where, my concern is that there needs to be a big emphasis on recovery and, not just let the person done with treatment, goodbye. Engage them, then have some, recovery support. We only have 2 recovery centers in New Jersey. Actually, I wrote the RFPs to develop them, and then we hear wonderful things about them. So to me, that's something we need more, like recovery centers in all 21 counties. So I'm just looking for suggestions. We're trying to do the right thing. We created family support centers. That was another thing that didn't exist in the addiction service area. So we now have 3 regional family support centers to help support family members. So I'm just open to any other ideas. We just set up a new telephone recovery support line to offer encouragement to people who are struggling with their recovery. But I feel sometimes like it doesn't seem to matter. Our overdoses are still increasing.
Why do you think they're increasing?
I don't know. Fentanyl is a big problem. Oh, well, one of the things, New Jersey, we're prime, right, for, distribution of drugs. The ports, everything, so we've got lots of, supply here in New Jersey, high quality heroin, very cheap, and now with, the fentanyl being mixed in, so that kind of is, I don't know, fighting us. We've got that issue going on.
Do you feel we're going to be facing a world where ready access to all kinds of drugs is just going to be a fact of life, and that our programs have to be built with an assumption that that's the case?
I don't know. I'm hoping, we're collecting data on our programs, that at least for those programs, we're not going to see big overdose death problems, but that I would like to see and hope that would be one of the outcomes. We can't reach everybody, right? We have limited funds, so, perhaps those people that are overdosing just haven't had the opportunity, to come to one of, these new programs that we're trying to develop. We're hoping for certainly good outcomes from our new programs.
I have a question I can't pronounce your last name. Doctor. So I saw on one of your slides that while opiates, the use of opiates has gone down, but the use of cannabis has gone up. And with the legalization and the use of medical marijuana within the United States, and I'm not sure how your policy is, and then even if that's been considered as, and not a fixing, but has that been seen to help with addiction to opiates? Just curious.
What you saw in the slide is treatment demand related to those drugs is increasing. Okay.
Also, the treatment plan for medical cannabis use.
Yes, the total number of users of cannabis, for instance, I'm not sure that is increasing. People who are seeking for help, most of them preferred by the administration.
The data are in the United States that marijuana legalization states have seen a decline in opioid-related deaths.
Now, we do not have that dimension. People are not shifting. Let's say, what we have for sure is a decline in opioid users. Heroin. So, and it was not replaced, at least, by those new opioids such as fentanyl. We do not have yet.
But then an American policy for those who up here that are, is that something that you guys are even looking into, or that's not even in the realm? I'm just curious because I do see in so many states that it is becoming used for medically. I know Ruby Lake has just released a documentary that she did called Weed the People, and she really kind of went around with cancer patients. She was in America, so I'm just curious.
The work that my office is doing here is not looking at cannabis. I do know from looking that folks are trying to think of it as a substitute for opioids, but we have not done it.
Because I know that, like you guys are talking about morphine and methadone, but that's just kind of going outside the box of even that. So I was just curious.
think that the opioid has been treated for pain. And then people using medicinal marijuana or cannabis as a substitute for the opioid and the treatment of pain.
Exactly.
So buprenorphine would be in the treatment for the addiction.
Doctor, I'm curious as to whether or not, as the success of your program has improved over the years, whether or not you've noticed a reduction in the number of cases of mental illness, such as depression, bipolar disorder, schizophrenia. Is there a corresponding decrease in that as your... No.
Our responses in mental health are still increasingly overloaded with the number of patients that kind of mental health conditions. We do not notice the same level of treatment as to drug use, mostly.
Does that surprise you?
I might point out in the United States, the suicide rate has gone up 38% since the late 90s. And the antidepressant treatment has increased radically in that same period, so that there are 3 times as many people on long-term antidepressants. Antidepressant treatment and suicides have risen consecutively in the United States for the last since 1998.
Interesting.
I don't want to take time from folks if anyone else wants to ask a question, but I can't help myself, so I'm sorry about this. To your question about what else can be done. Again, I think treatment, as Portugal has shown, is great, but people die of overdose because they use drugs, right? Not because they're in treatment. So the question is, what services do you have available for people who use drugs? And so I think all of that, the example of Portugal, low threshold, availability of needle exchange, methadone low threshold, or buprenorphine, decrim, so people are coming for services. Because I find that really curious that we think that a cure for overdose, that we may disagree here, is treatment. And it is for a small amount of people who are going to go into treatment. But most people are not in treatment, and it's people who are using drugs and are dying. So let's offer services for people who are using drugs.
Drug consumption sites?
Right. I mean, all of that, harm reduction. And here, New Jersey is not in the best spot. Again, 6 needle exchange programs across the state. And I think something that you said, João, is really important, that even if people don't go into treatment, but that pathway is open to them, to services, then that's a great thing. And if we had harm reduction programs across the country, and across the state, and if people were coming to them, then the pathway is open to naloxone, to treatment, to developing a relationship. But we don't have services for people who are users. And it's users who are dying of overdose.
The other thing I just wanted to add to what you're saying is increase the use of naloxone and Narcan distribution throughout the state as well is definitely an important thing. We do have 6 syringe access programs, but in the state of New Jersey, I know the Department of Health is looking to increase those sites because that's really a big goal of what Commissioner Elma Hall wants to do. So we were the 49th state in the nation to actually get a syringe access program, so we haven't been very progressive in that, but I think, with the new leadership, I think that's one of the things they're looking at doing.
Another way of describing what you said is teaching people and facilitating people to use drugs in better and safer ways. That's a giant leap in thinking anywhere, but in the United States especially.
Okay, sir.
In Switzerland, there are high levels of prescribing of opioids for pain control. Yet Switzerland has almost no overdose deaths involved in opioids, whether it's street opioids or prescription opioids. Germany has something like 200 overdoses involving opioids per year, 100 or so heroin-related overdoses, and the rest is kind of a mix. And so these are countries that are prescribing opioids not at the same rate as the United States, but still at very, very high rates, and they do not have the problem that we have in this country. And so I have been trying to kind of figure out, well, why is that the case? And I think one of the approaches that you see in a country like Switzerland or Germany is holistic pain management, where it's not just a prescription, which is the easiest way, and for many doctors in the U.S., the only intervention that is often covered by insurance. And so I wonder to what extent is it the way the healthcare system functions in this country that is a big part of the problem. And so I wonder in Portugal, I think illicit opioid use or prescribing in Portugal is probably lower than it is in Switzerland or Germany. But I wonder kind of what you are seeing in terms of prescribing of opioid painkillers and overdose deaths or entry into treatment because of addiction to painkillers.
So I think we have different medical cultures. Different medical training. We use opioids, as I said, I am a family doctor, and I use opioids quite often. But it's a second, third line prescription. After I physio, my patients who come with pain have access to other kind of intervention. They help them deal with pain. And with my mild painkillers, I can manage that pain. So I have a lot of options before going into opiates. What I feel that happens here, from what? As a family doctor working in the Algarve, the touristic area of Lisbon, I was very often called to hotels to see tourists, namely Americans. And I was completely astonished with the travel pharmacy that they were carrying. For managing diarrhea, they have opiates with brews, something else, whatever. But opiates were there. And they bought those pills in supermarket, not for us it's completely unthinkable. That kind of, we need a special form to prescribe opioids. and they are collected by the medicines agency. So, when they know, well, in Coimbra there's a huge number of prescriptions of a given or opiates. What is happening there? They may Zoom, and the medical council may Zoom on it and try to understand. And if needed, they call the doctor or the doctors that are over-prescribing. Okay? Explain what's happening in your area of intervention. Of course, nobody will forbid them from prescribing, but they have to explain to their peers. So, and I think this peer control is very effective. And it's not in our habits, in fact, to take or to prescribe opioids. Like the professor said, okay, we overprescribe and suddenly we take it off, so people have to go together on the street, in the street. That's not the case in our country. In this case, those are completely different realities.
Carol.
I wanted to go back to what Suzanne was talking about in terms of we're getting so many things online to actually treat, particularly acutely, what's going on. And yet we're having overdoses and the number keeps going up. And what I'm connecting it to is the fact that our whole system hits it and then quits it. So we go through, we get people off of the drugs, we put them in a short-term treatment, maybe a little more long-term treatment, but we're not dealing with the social determinants that we have to build in if people are going to be satisfied not being addicted to something. And I think until Medicaid, because we're talking about the public system, we're talking about Medicaid as a main funder, can really fund those social determinants, I think what we're doing with ORCs and the STAR programs is fabulous. We're setting up case management systems that really follow people and link them. But it's not long enough. And we're not building in those social determinants because at this point we're not covered for that. So I think we have to build that in if we're really going to see success with folks. And I think it goes with what the panel has been talking about. And it's right there. So I think that's one of the pieces that we're supposed to do.
Good point. We have time for a couple more questions. Yes.
I was just wondering if you could speak to, because a couple years ago I know Congress was trying to outlaw a natural opioid, kratom, and I know that that's a substance where it's a very low level impact and can be used maybe in a way like methadone. Were there any of you like experience or views on the use of kratom as a kind of way of weaning off?
We have no experience.
Good question.
Good question.
New pharmaceutical. Okay. Anyone else? Okay, if not, I really want to thank our panelists again for outstanding questions. I hope this is one in the series. This will be recorded.